Sure. So TRIPP-FFX was a trial designed to assess the feasibility and tolerability of a combination of induction chemotherapy with FOLFIRINOX and the implantation of a particular form of brachytherapy that consists in the implantation, intratumor implantation of P-32 charged microparticles. This is done endoscopically. So the microparticles charged with P-32 are implanted directly in the tumor during endoscopic ultrasound. And in the TRIPP-FFX trial, this was done within 4 weeks from the initiation of chemotherapy. The aim of the study, which was a randomized non-comparative study, was actually to explore the safety and tolerability of the combination, and also to look at, as the primary endpoint, at the local disease control rate at 16 weeks after the starting of chemotherapy. And for this very reason, as we chose a sort of a time-based endpoint, and also to control for some bias that could be introduced by the selection of patients within a small trial, we decided to have it randomized to just FOLFIRINOX alone without implantation. So although this was not meant to compare the two regimens, the FOLFIRINOX alone arm served as sort of a calibration arm to see whether our population of patients was in the range that is expected for this stage of disease. So basically, we aimed at excluding local disease control rate at 16 weeks lower than 55%, and aimed at assessing local disease control rate at 16 weeks over 70%. And actually, it turns out that in the 45 patients that were randomized to the P-32 microparticle implantation together with FOLFIRINOX, the local disease control rate at 16 weeks was 82%. So well above the threshold that we set. This was true also for the calibration arm with FOLFIRINOX alone, that was more or less in the same range, around 86% local disease control rate. And then we analyzed the population of patients in terms of safety and tolerability, and we didn't see new signals. So remember that the P-32 microparticles had already been tested in combination with gemcitabine-based chemotherapy in locally advanced disease. So we didn't identify new signals of potential toxicity in this population of patients together with FOLFIRINOX. There was in general no excess toxicity in the combination arm as compared to the FOLFIRINOX arm. The hematologic toxicity was slightly higher than what we saw in the calibration arm, but it is most probably due to the fact that these patients were checked before and after implantation for blood count, so it was easier to find, for example, neutropenia or platelet counts going down. Nothing major though, and there were only 6 events that were related to implantation, 6 adverse events related to implantation, so it's less than 15% in our population. And the adverse events of special interest that had to do with the inflammation of the GI tract, possibly due to the radiation part of the therapy, well, actually well balanced between the two arms, even without implantation. So this is the results in the intent to treat population. Then, so all patients that were randomized, which were 42 in the FOLFIRINOX arm and 45 in the FOLFIRINOX plus P-32 microparticles arm. And then we looked at the per protocol population, because 5 patients were not implanted, that were assigned to the combination arms were not implanted because at the CT scan before implantation, they were found to be progressive on the liver, so they were not implanted. And so these patients are not counted in the per protocol because they did not receive the implant. And 2 patients in the FOLFIRINOX arm were not counted in the per protocol because never received FOLFIRINOX. So if we look at this per protocol population, so exactly the patients that received the therapy that was intended for them, we do see a higher rate of responses in the combination arm, 56% against 35%, which is what you would expect with FOLFIRINOX. And all the time-based endpoint, PFS, OS, and time to local disease progression were numerically higher in the combination arm as compared to the FOLFIRINOX arm. But of course, this was not comparative, so we didn't formally assess the statistically significance of the differences. In general, we saw a very promising overall survival, median overall survival in the combination arms with 18 months in the intent to treat population and 23 months in the per protocol population. So this is at the high end of the spectrum of whatever recent trial you're looking at that combines systemic treatment with some form of local consolidation in local advanced pancreatic cancer.